Congenital adrenal hyperplasia in adults. CAH is a group of inherited disorders characterized by the deficiency of an enzyme necessary for the cortisol biosynthesis. This leads to increase of the precursors and diversion to other steroid pathways such as androgens or mineralocorticoid production. 90% of the cases are due to 21-hydroxylase deficiency. Clinical presentation depend on the severity of mutation. It can present in the neonatal period with salt wasting and virilization to non-classic CAH, which is present in adulthood. Complete enzyme deficiency basically it present in infancy due to the mineralocorticoid and corticosteroid deficiency with salt wasting crisis and ambiguous genitalia in female. Partial enzyme deficiency may present in later life with hyperandrogenism or premature puberty in case of non-classic CAH. It is autosomal recessive, and the carrier frequency of classic CAH is 1 into 50 to 1 in 100 in Caucasians. CYP21 encodes 21-hydroxylase enzyme. It's located in the short arm of chromosome 6. It is in close proximity to CYP21 pseudogene with 90% homology with no functional activity. There is a correlation between the severity of the molecular defect and the clinical severity of the disease. Non-classic CAH is usually due to point mutation, basically from the single base change. Missense mutation can result in simple virilizing disease, whereas gene conversion or partial deletion may present in infancy with salt wasting or severe virilization. 21-hydroxylase deficiency results in aldosterone and cortisol deficiency. Loss of negative feedback from cortisol results in ACTH hypersecretion, which in turn causes adrenocortical hyperplasia and accumulation of the steroid precursors above the enzyme deficiency, including progesterone and 17-OHP. These are then shifted into the androgen synthesis pathways, resulting in testosterone and androstenedione excess. 11-beta-hydroxylase is the next commonest deficiency, but in addition to causing hyperandrogenism, it can lead to accumulation of 11-deoxycortisone, which acts on the mineralocorticoid receptor to cause hypertension and hypokalemia. Clinical presentation. In the classic CAH, it is diagnosed in infancy, and those patients in which classic CAH persisting into adulthood, sexual dysfunction and subfertility are observed in female, particularly those with salt wasting syndrome. Reconstructive genital surgery is required in the majority of female who were virilized at birth to create a suitable vaginal intritus. With improvement of the medical care, normal pregnancy rates around 90 have been achieved. In male, high levels of adrenal androgens suppress gonadotrophins, thus testicular function. Increased ACTH results in the development of testicular adrenal rest tissue starts. These are always benign, but may be misdiagnosed as testicular tumors. TARTs can be destructive, leading to testicular failure. Spermatogenesis is often low if CAH is poorly controlled. There is a significant risk of adrenal crisis over the lifetime. In the non-classic CAH, it is due to partial deficiency of 21-hydroxylase. Glucocorticoid and aldosterone production is normal, but there is overproduction of 17-OHP, thus androgens. Patient may present with hirsutism, acne, oligomenorrhea, and often found around the time of puberty. Polycystic ovaries can be present on the ultrasound, and adrenal syndromas or hyperplasia are also seen in 40% of the patients. It is asymptomatic in males. The effect of non-classic CAH on male fertility is unknown. So the investigation of CAH in adults. Because of the diurnal variation in the adrenal hormonal secretion, all investigations should be done before 9 a.m. Timing of the measurement, screen in the follicular phase of the menstrual cycle, 17-OHP is produced by the adrenal and corpus luteum. So false positive results may occur if measured in the luteal phase of the cycle. Interpretation of the results. If patients having menstrual cycles measured in the follicular phase, if it is less than 6 nanomole per liter, it is normal. If it is greater than 13 nanomole per liter, then it is most likely CAH and proceed to additional test. If it is between 6 to 13 nanomole per liter, proceed to ACTH stimulation test. A fifth will have a non-classic CAH. In the ACTH stimulation test, we measured the 17-OHP 60 minutes after ACTH administration and cortisol at 30 minutes. This exaggerated rise in the 17-OHP is seen in non-classic, and that is at 60 minutes, 17-OHP would be between 30 to 300 nanomole per liter. Patients with classic CAH typically have a 60-minute OHP levels greater than 300 nanomole per liter. 17-OHP less than 30 nanomole per liter post-ACTH excludes the diagnosis, and the levels of 330 to 45 nanomole per liter may suggest heterozygosity or non-classical CAH. Cortisol response to ACTH stimulation measured at 30 minutes is usually mildly low or normal in non-classic CAH and low in classic CAH. Other investigations include 24-hour urine steroid metabolite profile. A normal urine steroid profile excludes the diagnosis of CAH and therefore should be considered in all cases, especially when there is clinical uncertainty or the discordant results. Androgens in poorly controlled classic CAH in female, testosterone and androstenedione levels may be in the adult male range. Androstenedione sulfate levels are usually only mildly and not consistently elevated in CAH. Circulating testosterone, and particularly androstenedione, is elevated in non-classic CAH, but there is a large overlap with levels seen in PCOS. Renin plasma renin activity is elevated due to aldosterone deficiency. A proportion of female with non-classic CAH may also have mildly elevated renin concentrations. ACT is greatly elevated in poorly controlled classic CAH. It's usually normal in non-classic CAH. Genetic testing provides the definitive diagnosis where specific mutations are identified and should be offered to all patients and to their partners if pregnancy is being planned. So enzyme deficiency in CAH, in classic 21 hydroxylase, there would be salt wasting, ambiguous genitalia in female, and precocious puberty in male. While in non-classic 21 hydroxylase, there would be partial deficiency, and this would lead to hirsutism, oligomenorrhea in pubertal female. It's asymptomatic in males. In case of 11-beta hydroxylase, there would be ambiguous genitalia, virilization, and hypertension. So it is just like 21 hydroxylase, but there would be hypertension as well. In 3-beta hydroxysteroid dehydrogenase type 2, HSD3 beta deficiency, there would be mild virilization, salt wasting in severe cases. And in case of P45-450 oxidoreductase, there would be ambiguous genitalia, skeletal malformations, and the syndrome is called Antley-Bixler syndrome. Is possible maternal virilization in pregnancy and no postnatal virilization. In 17-alpha hydroxylase deficiency, there is delayed puberty in female, pseudo-hermaphroditism in male. There would be hypertension and hypokalemia. In star, lipoid CH, classic and non-classic forms with degree of genital ambiguity and adrenal insufficiency, including salt wasting. And in case of cortisol side chain cleavage, classic and non-classic forms with degree of genital ambiguity and androgen adrenal insufficiency, including the salt wasting. So to summarize, in case of classic CAH, there would be low hypotension, ambiguous genitalia. In non-classic, it is just like PCOS, PCOS-like presentation. In 11-beta hydroxylase, there would be ambiguous genitalia, virilization, and hypertension. Management of CAH in adults. So the aim of treatment in adulthood under specialist care are to minimize the to maintain the normal energy levels and weight and avoid the adrenal crisis, to minimize hyperandrogenism and restore regular menses and fertility in female, to avoid glucocorticoid under or over replacement. So classic CAH, hydrocortisone should be considered as the first-line treatment. All the low-acting glucocorticoids can be used. Prednisolone, total dose of 5 to 7.5 milligram per day, given into divided doses, which is no longer a reverse circadian pattern. Occasionally, patients who are not controlled on prednisolone may be treated with nocturnal dexamethasone instead in the dose of 0.25 to 0.5 mg nocturnal. Occasionally, additional progesterone to induce withdrawal bleeds is needed. The optimum dose is the minimum dose required to normalize the serum androgens. Dose titration should be achieved using androstenedione rather than 17-hydroxyprogesterone to guide the management. As with other forms of adrenal insufficiency, glucocorticoid doses should be doubled during illness. All patients, children and adults with classic salt wasting CAH require mineralocorticoid replacement. Fludrocortisone 50 to 200 microgram per day is given as a single daily dose. Fludrocortisone dose should be titrated according to clinical symptoms, electrolytes, postural BB, and renin concentrations. Addition of androgen receptor antagonist OCP may be required for the hyperandrogenic symptoms. Spironolactone is relatively contraindicated in CAH due to potential for salt wasting. So spironolactone is not used in CAH. Bilateral adrenalectomy reduces the risk of virilization in females and allows for the decreased glucocorticoid doses. However, it also carries surgical risk and is not recommended for patients discordant with steroid treatment. Furthermore, due to potential for the ovarian retroperitoneal or TART adrenalectomy may not effectively control hyperandrogenemia. Thus, it is occasionally considered in those with unsatisfactory outcome with conventional medical management, but it is not routinely recommended. Periodic testicular ultrasound is useful in male with CAH to monitor for TARTs. In case of pregnancy, patient and partners require prior CYP21 mutation analysis at the earliest opportunity to enable genetic counseling. If partner is carrier, there's a 50% risk of affected child. 1 in 63 is a carrier of the 21-hydroxylase gene. Bone health should be monitored. In non-classic CAH, treatment should only be considered in symptomatic individuals or in the context of pregnancy. When there is oligomenorrhea, prednisolone 2.5 to 5 mg per day may be used, but it may often reverse to normal the ovulative function. If asymptomatic, avoid the use of glucocorticoid. If previously treated, give option of discontinued therapy when adult height is achieved. Stress dosing recommended for the major trauma, surgery, or childbirth only if suboptimal cortisol responds to short synectin test. For hirsutism and acne, may alternatively more effectively treated as for the PCOS. Spironolactone should be avoided because of the potential risk of the salt wasting and hyperenemia. If the plasma renin level is elevated, then fludrocortisone given in the dose sufficient to normalize renin concentration may improve the adrenal hyperandrogenism. Males may not require treatment. The occasional may need glucocorticoid to treat subfertility although excess glucocorticoid may suppress gonadotrophins. In adult patients with adequate adrenal cortisol reserve, consideration should be given to withdrawing glucocorticoid therapy if symptoms have improved. Management of pregnancy in CAH, maternal classic CAH. If the mother is having classic CAH, genotyping of the partner may be used as the first line. Alternatively, screen patient partner using basal plus minus ACTH stimulated 17 OHP levels. And if levels are elevated, proceed to genotyping. If they are heterozygous, then pre-implantation genetic diagnosis using IVF treatment or prenatal treatment of the fetus may be considered. Physiological prednisolone or hydrocortisone rarely needs adjusting in pregnancy. It is increased by 20-25% during the third trimester. Fluorocortisone dose not normally need to be adjusted. Routine biochemical markers cannot be used in pregnancy to treat symptomatology. Dexamethasone crosses the placenta, so should not be used unless aiming to suppress the fetal adrenal function. Adjust fluorocortisone against the BP, but alteration during pregnancy is not normally required. Placental aromatase protects the fetus from the maternal androgens. Greater than 200 pregnancies reported to mother with CH with no case of fetal virilization recorded. Greater than 75% cesarean section rate because of the masculinized pelvis and surgical scarring following vaginoplasty. There's increased risk of GTM, and routine glucocorticoid boost should be given at the onset of active labor. Prenatal treatment of the pregnancy is at a risk of CH. Aim of the prenatal treatment is to prevent virilization of the affected female fetus. Only it should be considered if previous child from the same partner with CH are known mutation in both parents. Mutation must be identified well before trying to conceive. It is not for mothers with CH unless partner is a known carrier of a severe mutation. Only it should be considered by the experience unit. Current guidelines consider this still in the realms of research, and the long-term outcome of dexamethasone exposure to unaffected fetus is unknown. Treatment should be commenced before 7 weeks gestation. Dexamethasone 20 microgram per kg maternal body weight in 3 divided doses a day crosses the placenta and reduces fetal adrenal hyperandrogenism. If possible, aim is to collect the circulating DNA at 540, and if the female fetus commences dexamethasone from 7th week onward, discontinue if there is a male fetus. 50 to 75% of the affected females do not require reconstructive surgery. So monitoring of the treatment, annual follow-up is usually adequate in patients, in adults. Measure BP and weight, look for the evidence of hyperandrogenism and glucocorticoid excess. Amenorrhea in female usually suggests inadequate therapy, but may be accepted, as often cannot be achieved without excessive doses of glucocorticoid. Try progesterone for the withdrawal bleed. Consider the use of intermittent progesterone-induced withdrawal bleed. Androstenedione levels can be used to titrate glucocorticoid dose, aiming for the mid to upper normal range. Suppressed levels of 17 OHP, testosterone, and renin are an indication of overtreatment. Normalizing will often result in complications from supraphysiological doses of glucocorticoid. Therefore, use androstenedione as a guide, but do not aim for the suppression in order to avoid adverse effects of overtreatment as well as the clinical features. Modesty rates are high normal levels of 17 OHP, testosterone or renin are optimal. ACTH monitoring is not useful. Consider bone mineral density, which may be reduced by the supraphysiological steroid doses. Testosterone function requires special attention. Low LH is a sign of raised adrenal androgens. Raised FSH may follow adrenal rest as a sign of testicular failure. Ultrasound tests should be done every 2 years. Consider sperm count storage if adrenal rest are present. Ultrasound ovaries are not useful routinely as PCO morphology is common. In men, testicular adrenal rest tumors may develop in up to 90%, 94% of the patients. Consider 5-year adrenal imaging. The detection may prevent infertility later. Consider semen cryopreservation and ultrasound screening of the scrotum is suggested every 2 years. Prognosis. So height, despite optimal treatment in childhood, patients with CH are on average significantly shorter than their predicted genetic height. Studies suggest that this may be due to overtreatment with glucocorticoid during infancy. Fertility, mainly a problem in male with poorly controlled classic CH and adrenal rest. Adrenal centillomas, benign adrenal adenomas have been reported in up to 50% of the patients with classic CH. Male with CH may develop gonadal adrenocortical rest. Psychological issues, gender dysphoria is common in female.